Hello, everyone. Thank you for your patience. I appreciate everyone joining us today. For those who are streaming this live now and who will be watching this later, we're thrilled to have you on these last few days of Lupus Awareness Month 2024. Welcome, and thank you for joining us for our special educational symposium in honor of Women's Health Month and Lupus Awareness Month. My name is Kelly, and I am the creator and executive director of the Portland-based nonprofit More Than Lupus. And if you're unfamiliar with More Than Lupus, we are a multi-ethnic, multi-generational, and international lupus community designed by lupus patients to connect and to grow and to inspire each other throughout the peaks and the valleys of our lupus journeys. And I say our because I have lived with systemic lupus and multiple lupus overlap conditions since the age of 11. I'm a pediatric patient. Now, we believe that every person living with lupus, no matter their background, should be treated with equity and dignity and taken seriously. And it is our mission that patients feel heard, that they feel seen, and they feel valued. And it's also our plan of action to continue to spotlight minority populations disproportionately affected by lupus and lupus nephritis. So today's event will spotlight the unique interplay between lupus and reproductive health. Now, we hope that the information provided today can be used as a resource that propels you to have an open and honest conversation with your doctor, with your doctors, about ways that you can become more engaged with your reproductive health and the various challenges that it may present in different stages of life. By the way, make sure, I see some people are already doing this, you know what I'm about to say, make sure you share this live event on your personal Facebook page so that people can get connected to community, to support, and have access to some incredible information and resources that will be shared today. Also, anyone who writes shared in the comments will be entered to win a Lupus Awareness Month swag bag with some added goodies from our walk that we had last Saturday. So before I introduce our special guest today, please allow me to give you a brief disclaimer. Please understand that the opinions shared today are purely for informational purposes and do not replace the medical advice and/or opinions of your doctor. If you are experiencing lupus, lupus nephritis, lupus overlap symptoms, or problems with your reproductive health, it is important to follow up with your doctor and to seek the treatment that is best for you. Our panelist is a qualified professional. However, they are not liable for their comments since they are not acting as your personal physician or health advocate. It is time that we as a patient community delve deeper into this conversation, which doesn't get talked about as much as it should. And I'm thrilled to have Dr. Megan Lockwood, Assistant Professor of Medicine, Georgetown University School of Medicine, and Director of the Lupus Program at Medstar Georgetown University Hospital, joining us today to further this discussion. Hello, Dr. Lockwood.
Hi, Kelly. Thank you so much for having me.
It is a pleasure to have you here with us during Women's Health Month and Lupus Awareness Month. And I think it's World Reproductive Health Day today. We're checking all the boxes, aren't we?
We sure are.
Well, I'm very pleased to say we've got a lot of people joining us live, and Dr. Lockwood has graciously decided to stay on with us after her presentation to answer any questions. So please write your comments, your questions, your concerns in the chat box, and we'll do our best to get through as much as we can before the hour is up. But Dr. Lockwood, take it away.
All right. Well, Kelly, again, thank you so much for the invitation to speak with you and More Than Lupus today. I think the work that you guys do and the commitment you have to the cause is just it's so impressive and humbling. So I'm delighted to get to be here today and talk with you about one of my favorite topics, which is lupus and reproductive health. And so I hope that we can, spend a few minutes going through these slides, and then I hope that this will really stimulate a discussion, and I'd be happy to answer any questions to the best of my ability that I can that will be most helpful for you. So just to start out, I thought we would start by talking about pregnancy. And as we know, lupus is primarily a disease of women of childbearing age. So it's really important to always think about pregnancy and lupus. And what I really want to highlight is that a healthy pregnancy with lupus is possible. But lupus raises your risk for certain complications during pregnancy. And if you have lupus and you're thinking about getting pregnant, it's really important that you work with your team of doctors to plan a healthy pregnancy. And for a long time, people were told that young women with lupus should not get pregnant. But we have learned that in the majority of cases, people with lupus can anticipate a safe pregnancy. If you have had really active kidney disease, or if you happen to have a coexisting lung disease called pulmonary hypertension, you will probably have a much higher risk pregnancy. But really, over 95% of people with lupus end up doing just fine. So the take-home message should really not be, oh my gosh, I should not get pregnant. The take-home message really is that the best pregnancy in lupus is a planned pregnancy, and I should make sure to talk about this with my providers so that I can get my disease under good control and be on safe medications. And so these are really the most common questions that I get from people with lupus when they're starting to think about family planning. I think the number one thing that people with lupus will want to know, or really anybody with a chronic illness will want to know, is whether their disease is going to flare with pregnancy. The second thing that people will typically want to know is what medications can I take safely during my pregnancy? And finally, is the disease going to impact my pregnancy outcome? Does that mean I'm going to have a worse pregnancy outcome? And it's so important for patients with lupus to talk with their providers when they're anticipating pregnancy, because what we really want our patients to understand is that when they get pregnant, it needs to be when your disease is under good control and when you're on medications that you can safely continue during pregnancy. And we know from many studies that if disease is under good control when you get pregnant, then you're much more likely to have a good pregnancy outcome, both for mom and for the developing fetus. So it's really important that you communicate with the team who's in charge of your lupus to discuss your intentions and your plans around family planning. So again, we really want to make sure that your disease is quiet before you get pregnant. If you've had a history of kidney disease, or if your disease is active at the time of conception, then there's a much greater risk of having a lupus flare during pregnancy than if you weren't pregnant. We really worry about the progression of kidney disease during pregnancy. And we always worry about the aggression of different organ manifestations, including renal disease, when that happens, because we'll often have to use treatments such as very high doses of steroids and other very strong immunosuppressive agents that can potentially be harmful for a developing fetus. So we know that mom and baby do best when the disease is quiet. But part of why planning for pregnancy becomes important is that you will sometimes need to stop certain medications and switch to something that's safe for pregnancy. And you really need to take time to make sure that your body responds well to the new medications and that your lupus doesn't flare. So the typical rule of thumb is that we want you to be on completely safe lupus medicines and have your disease be completely quiet for 4 to 6 months before you try to conceive. So this is a list of medications that are compatible with pregnancy, safe with pregnancy. Azathioprine or Imuran is a medicine that is incredibly safe during pregnancy. We use that in a lot of our patients with lupus, including lupus nephritis. Chloroquine and hydroxychloroquine are very safe during pregnancy. And actually, hydroxychloroquine has been proven to have benefits both for the mother and for the developing fetus during pregnancy and may actually reduce the risk of something called neonatal lupus. NSAIDs, so non-steroidal anti-inflammatories like ibuprofen, Motrin, Celebrex, those typically can be used up to 20 weeks, but after 20 weeks, we like to discontinue them. Prednisone is also considered to be safe at the lowest dose possible during pregnancy. Ideally, we would keep that below 20 milligrams a day. And then sulfasalazine and tacrolimus or Prograf are medications that are considered compatible with pregnancy. These are the medicines that are really important to be aware of that right now are not compatible with pregnancy. Cyclophosphamide or Cytoxan is probably a medication that you have heard people talk about when it comes to both pregnancy and fertility. This is a medication that has a lot of effect on fertility for women and for men. It's a medicine we really try not to use in pregnancy unless there is life-threatening active lupus in the second and third trimester. Belimumab or Benlysta, one of the newer medications that we use for lupus, is not a medication that we currently recommend using in pregnancy. We don't have a lot of great data. There are not a lot of great studies examining the safety of Benlysta in pregnancy. My hope is that will change at some point, and we have had some patients continue on this medication during pregnancy and be fine, but we really don't have a lot of studies that have really bore that out yet. Leflunomide, methotrexate, mycophenolate, so Cellcept or Myfortic, are not safe medications to be on during pregnancy. Thalidomide and lenalidomide are also not safe medications to be on. Rituximab is something we typically continue through conception, and then we will add back to the second or third trimester if there's severe life-threatening disease. And part of the reason we say it's so important that a pregnancy in lupus is a planned pregnancy is because the damage that these medications can cause are typically very early on in the pregnancy, usually before you will even know that you're pregnant. So by the time you find out you're pregnant, if you're on one of these medications, damage very likely may have already occurred. So what you can see here on the right is when we try to stop the medications in timing with conception. And this comes from the Lupus Foundation of America, which I imagine many of you are very familiar with, and a really great resource for patients and providers. So again, we want to make sure that lupus is quiet and that you are on medications that are safe for pregnancy. And even with improvements in management over the years, the risks of pregnancy-related complications are still increased in people with lupus when compared to people who don't have lupus. And some of those complications can include pregnancy loss, either early or late pregnancy loss, premature babies, like premature delivery, small for gestational age infants, so low birth weight babies. And then there's higher than average risks of other pregnancy-associated conditions, such as gestational hypertension, which means high blood pressure during pregnancy, preeclampsia, and even eclampsia. It's really important to know your antiphospholipid antibody status. This becomes so important in many conversations, not just surrounding pregnancy, but in reproductive health in general. And I really want to empower you to know your antiphospholipid antibody status. These are antibodies that can be seen in people who have lupus, but they can also be seen in people who don't have lupus, who have other autoimmune diseases or don't have these. We often hear about these antibodies with something called antiphospholipid syndrome, but you don't have to have antiphospholipid syndrome to have these antibodies. And the reason it's so important to know your status about these antibodies is that in some patients, it can actually contribute to clotting or kind of an inclination to form blood clots. And in some patients, that can actually increase the risk of pregnancy loss, whether that's recurrent pregnancy losses in the first trimester or once you get into the second trimester. There's also an increased risk of preeclampsia when these antibodies are present. And so when people have lupus and these antibodies, it really adds more risk to your pregnancy. And there might need to be some additional medications and or monitoring that's required when you get pregnant. I also want to encourage you to know your status when it comes to the Rho or LA antibodies. Rho is also known as the SSA antibody. LA is also known as the SSE antibody. And these are antibodies that are seen in both lupus and Sjogren's. And again, part of the reason it's so important to know your status about these antibodies is that you can have these in your blood even without Sjogren's or without lupus. Now, you can't directly give lupus to your baby. That's just not how it's passed down. But when you have these antibodies, the Rho and LA antibody, they can actually be passed to the developing fetus, and the baby can develop something called neonatal lupus. Now, neonatal lupus is not the same type of lupus that adults get or kids. And it doesn't mean that these babies will have lupus when they grow up. But these are babies that can develop a severe rash on their face that usually goes away within 6 months of birth. Rarely, these babies can get a condition called congenital heart block. And that is something that can actually be identified during pregnancy. And it's really important that this gets monitored for, because usually when babies have this congenital heart block, they will need immediate care after birth, including potentially needing a pacemaker to control their heartbeat. So when people have these antibodies, there's actually special testing that we do. We do fetal ultrasound, so ultrasounds of the developing baby's heart to monitor for this during the pregnancy. So knowing your status is a really important part of a safe and healthy pregnancy for you and your baby. So switching gears a little bit, when I'm speaking about when I'm speaking with a lupus patient or anybody that has lupus, we'll always try to talk about, what is your birth control plan? What are your family plans? Are you thinking about getting pregnant in the next year? And if you're not, then we should think about birth control, because so many of our medications can cause problems early in pregnancy, like we discussed. And so the first thing I really like to establish with all of my patients, again, is do they have these antiphospholipid antibodies? And the reason that's important is because if they're positive, then categorically, we are going to avoid all estrogen-containing birth control options. So that's things like combined oral contraceptives, the estrogen patch. We really want to avoid those. There are still options like progesterone only containing birth control and IUDs. But after the antiphospholipid antibodies, then we like to further think about people who've had more mild disease compared to people who've had more serious organ involvement. And the reason that's important is because we've learned from several clinical studies is that people with mild disease with negative antiphospholipid antibodies can probably be on any type of birth control, including the low-dose estrogen combined oral contraceptives, or the pill. And we had some studies in the early 2000s that showed that people with very well-controlled lupus on low-dose estrogen did not have an increased risk of lupus flares. But again, those were all people who had negative antiphospholipid antibodies. In people who have had very active disease in the past or who've had very bad kidney disease, we really don't have any great data on whether estrogen-containing birth control is an option. So in general, most of us in lupus experts will try to avoid estrogen-containing contraceptives. What I would want to point out though is that the risk of having a clot with pregnancy, even without lupus, is quite high. So we really want to make sure that people who are at higher risks of clots, including those with lupus and with these antiphospholipid antibodies, have good contraception because of those risks. This is a graphic that I love from a great website. This is from the HOP STEP group at Duke. And if you just go to lupuspregnancy.org, you'll find this visual. And what I really like here is that this goes through so many of the common forms of birth control. And up here, I'm not sure if you can see my pointer, but up here at the very top, we have the highly effective options. Though when we say highly effective, we mean less than 1% chance of getting pregnant each year. And so that's a tubal ligation or vasectomy, an implant, or an IUD. The less effective options, but still pretty effective, 6 to 9% of pregnancy each year, that's when we see things like Depo-Provera, the pill, the ring, the estrogen patch. And then we have our much less effective options here on the right. Those are things like condoms, diaphragms, fertility awareness. These still work, but not nearly as well. And so what you see here is those that have the circle with the check mark, these are recommended. So for example, the IUD, that is recommended for everybody, whether you have a high risk of blood clot or whether you have high or low risk lupus activity. But as you can see, it gets a little bit more complicated with some of our less effective methods, whether it's safe if you're higher risk for blood clot or if you have high lupus activity. And I think the key here is that this is not always an easy decision and really important to talk about with your lupus doctor. It's important to also talk about with your primary care doctor and or your gynecologist, whomever might be prescribing your birth control, but you really want to make sure that your lupus doctor is a part of the conversation because these things can get complicated very quickly. One point I do want to make is that accidents happen. And that's what we have emergency contraception for, or the morning after pill, or Plan B, or similar medications. And these are medications that can effectively prevent pregnancy if taken within 3 days of having sex. And what I really want to highlight is these are safe for all women with lupus, even those at high risk for blood clots and those with high disease activity. So no prescription is needed for these medications. You can buy from your local pharmacy, or now you can even get on Amazon. And I think what's really key is that emergency contraception does not cause an abortion. Your gynecologist will have many other options for emergency contraception for you that you can use for up to 5 days after sex. So I encourage you to talk about that with them as well. But the take home here is that emergency contraception is safe for everybody. I want to switch gears again a little bit and talk about men and reproductive health. We often focus on women because 9 out of 10 people with lupus are born female. However, 1 in 10 people diagnosed with lupus are born male, and it's easy for us to forget about the guys in the conversation. And I think that we're trying to get better in recognizing the importance here. But what I really want to highlight are some of the reproductive issues that come up with men when they're thinking about family planning. For anybody with lupus, man, woman, we know that during the time of disease activity, there will be reduced fertility. That is just the nature of having a chronic illness and how that affects your body's ability to procreate. However, once their disease is under better control, then the next question becomes, what medicine should they be on at the time of contraception? So for men who are having female partners and ongoing vaginal intercourse, how is that going to affect fertility? We know that methotrexate is not safe for women to be on when they're pregnant, but what about men? It turns out that methotrexate is really not an issue for men and fertility. There's really only 3 medications that we worry about. First is cyclophosphamide. This can cause both permanent infertility and potentially cause congenital anomalies. So for any male patient that will be going on cyclophosphamide, we always have a conversation about sperm banking. It really should be considered so that you don't end up with permanent low levels of sperm, causing you to not be able to conceive later in life when you're ready to do that. Thalidomide is another medication that we suggest men stop when they're thinking about conception, not because of the fertility issues, but because there's actually a very, very, very small concentration of glutamate in the semen. And because of that, there is a potential teratogenic risk. And so that means harm to developing fetus. This is a medication that we really don't use very often anymore. We most often reach for it when people have very extreme skin disease. The last medication we think about when it comes with men and reproductive health is sulfasalazine, and that's because it can cause some patients to have a low sperm count. We don't typically stop this medication up front unless they're having difficulty with conception. And then we'll do a semen analysis and see if that's contributing to their fertility issues. But the reality is that most medications taken by men, once their partner is pregnant, they don't get concentrated in the semen enough to really impact what's being absorbed vaginally by the woman and then go on to hypothetically impact the developing fetus. So in this sense, men have it's much simpler. I think the final comment I wanted to make is just really highlighting how important it is to talk to your doctor about these things. These are things that we all can feel sensitive or a little embarrassed about when we're the patient. But as clinicians, we're trained to be good listeners, to not judge. Our job is to help people. That's why we went into medicine. And as providers, I promise you, we have heard anything and everything. And as a patient, you might not feel comfortable. But I promise that as a physician, it's not the first time that we're hearing it, and we're not there to judge you. Your duty really is to yourself and to focus on your health. And you can't do that unless you feel open and comfortable discussing all sorts of things with your provider. And high on that list is reproductive choices, sexuality, sexual function, contraception. And hopefully, as physicians, we're doing our job by asking these questions in an open-ended way that helps you to feel comfortable. So we want you to be your best self and your healthiest self. And if you are open and share these things with your providers, you're going to be able to do that. I think it's so important to remember that sexuality, fertility, and reproductive health are really important parts of having a good quality of life. And that's what every doctor wants for their patients. So it's really an important part of self-care to talk to your doctor about these things. So with that, I'll say thank you. We will pause right here, and I would be so happy to take any comments or questions.
Oh, thank you, Dr. Lockwood. Oh my goodness, I've been typing away on my sidebar here because so many great pearls of wisdom and encouragement, honestly, about a topic that, for whatever reason, in 2024 is still somewhat taboo, which shouldn't be, because as you said so well, this impacts your life, your quality of life in many ways. We have some questions, a couple that are pre-submitted, and then a few that are here in the chat box. So I'm just going to dive right in, and if you feel comfortable answering, just please go for it. There is a question about IVF and lupus safety. Obviously, for those that are choosing that as part of their pregnancy journey, it's not without its risks, especially because of the additional stress hormones can have on the body of someone who has lupus. Any thoughts and concerns or comments about IVF and pregnancy and lupus?
That is such a great question, and something that is so important for people who have lupus and who are affected by lupus. And what I would say is the most important thing is that the disease is in remission and that your disease is completely quiet. to be honest with you, we do not have a lot of data on the use of IVF or in vitro fertilization in lupus. And there is a theoretical concern that there can be a flare in people with lupus when they're in the setting of elevated estrogen levels. So what we recommend is you get your lupus under complete control. So we say 6 months of stable, inactive, or low level disease. But it's important to remember that there is a theoretical concern that during ovarian stimulation with elevated estrogen levels that may worsen active disease. But this is purely a theoretical risk. This really isn't something that's been borne out in a lot of studies. And I will say I've had many patients with lupus go on to have very successful IVF courses. We strongly recommend that you do not stay on cyclophosphamide if you are on cyclophosphamide when you are thinking about IVF. However, you can continue nearly all other immunosuppressive and biologic therapies through both ovarian stimulation and through the oocyte retrieval for cryopreservation. If you are planning to go on and carry the pregnancy, then you need to be on pregnancy-safe medications. However, if your disease is very active, then we do not recommend proceeding with any type of assisted reproductive technology until it's under control. And then the second thing that I would say is you really need to know your antiphospholipid antibody status because there is an increased risk of clots and there's an increased risk of fetal loss. And so for our patients who have antiphospholipid antibodies, whether they just have the blood tests, the antibodies, or whether they have full-blown antiphospholipid syndrome, we'll often use blood thinning medications during the procedures, whether it's ovarian stimulation or egg retrieval, etc. So at that point, it becomes really important that you're working with your fertility specialist, your lupus doctor, and your gynecologist.
Well, that's really fascinating. I don't think I have had the opportunity to hear a rheumatologist's perspective on IVF before. So I'm sure a lot of people who are watching this live and streaming this later are just very thankful for that information. What about, I know some people in our community have gone the route of freezing their eggs so that they could have more time later in whenever the time is that they're looking for to maybe get their ducks in a row, maybe, slowly taper off one medication to start another. Do you recommend that? Is that something you've had your patients do? Is it something that people should consider if they are female and thinking about starting a family, but just not quite ready yet?
That is a great question and something that I really try to encourage my patients to think about, especially if they're going to be, if we could anticipate that they might be starting cyclophosphamide. You're not always in the situation where you have a lot of time to do a procedure like that. But, embryo and oocyte cryopreservation or freezing, they're really good options to preserve fertility in patients whose condition is stable enough for them to undergo ovarian stimulation, but then who are either not able to or not ready to pursue pregnancy at the time of stimulation. And so for some people, we will actually do stimulation, ovarian stimulation and IVF, and then followed by an embryo transfer to a surrogate if some people have very severe, disease-related damage who really desire a biologic child, but cannot safely undergo pregnancy. So there are a lot of options, and I think this highlights the importance of really starting those conversations early on with your doctor and asking a lot of questions to know what your options are.
Interesting. Wow. My wheels are just going. So I'm throwing a lot at you here. So a lot of people in our community, including myself, have been in a predicament where we are on certain medications, as you mentioned, on the list that are not pregnancy approved, are not safe. And but we have stayed stable relatively stable because we have systemic lupus and lupus nephritis, and maybe the first line of treatment was CellCept. And then we're told, uh-oh, if you're thinking of starting a family, you cannot be on CellCept. What can you just kind of talk us through in this type of hypothetical scenario? What would be the next move for someone who's like, oh, I'm really scared to rock the boat here, but I know that this is what I want, and I know I can't be on this medication anymore?
Yeah. It is such a common question that we talk about in our lupus clinic all the time with our patients is, when do you want to rock the boat? It can be really scary because as you know better than anybody, you can be so incredibly sick and it can take a really long time to come out of that. And it can be really scary to think about stopping some of your medications if you're thinking about family planning or pregnancy or really for any reason. And so in that situation, what we'll typically do is we'll step back, we'll take stock of the disease. How long have you been in remission for? How severe was your disease? And then we'll go through and say, what medications are you on right now? And are these medications that are safe for pregnancy? And we'll usually identify some that aren't. And especially if you've had lupus nephritis, CellCept or mycophenolate mofetil or mycophenolic acid are the ones that we run into this the most. And what we'll do is we'll have a conversation about switching to a different medication. Usually that will be azathioprine or Imuran. We have very good data that medication is safe in pregnancy. So we'll try to continue that. But the key is we have to make sure that you're going to be okay on that medicine. Because, for a lot of people, if the disease is quiet, we can switch from mycophenolate to azathioprine and it's fine. But we need to make sure that your disease is quiet, because sometimes if you rock the boat, then you can't make that switch and your lupus nephritis gets worse.
Right.
But if that happens and you can't get off the medications, not all options are lost. And that's when you do think about ovarian stimulation and oocyte or embryo cryopreservation, like egg freezing, because you can still be on those medications and freeze your eggs. You might think about a surrogate. So it doesn't mean that you still can't have a biological child, even if you can't come off of those medications. And I think that's really important to understand, and something that we've all been told for a long time, that when you're on those medications, there's a no-go with fertility, and that's really just not the case.
Right. It's a hard line in the sand, or most of us have been told that for, several years. And it's interesting too, because you mentioned Benlysta being a medication that could potentially be safe, and many people think it is safe for pregnancy. There's just not the data. And I'm sure as a physician, there's always that hesitancy of not having that long-term data. Do you feel that might change in the near future? And we obviously have two new medications right now. We've got the Safnello, and there's not, you're the expert, I'm not, about the long-term data with Safnello as well, for pregnancy safety.
So let me step back and say, I think one of the challenging things about pregnancy is that so many medications, not just rheumatologic medications, have just not been studied in pregnancy for whatever reason. Drug companies, science, they're just not studied. And so it puts you in a really, as a patient, in a really uncomfortable position to have to make a decision without having the facts to really back it up. And I think we probably end up using far fewer medications. There are probably several medicines that are safe during pregnancy, but it just hasn't been studied. And it's a very hard position to put somebody in to make that decision for themselves and their baby. There are patients who have gone on to get pregnant with medications like belimumab and anifrolumab. The thing about, belimumab or Benlysta, anifrolumab, Safnello, rituximab, Rituxan, is they're what we call monoclonal antibodies. So they're a certain type of medication that can actually cross the placenta in the third trimester, just because of the structure of the medication. So the question then becomes, what happens if a fetus in the third trimester is exposed to these medications, and how will it weaken their immune system? And we don't have great data for it. We have a lot of theories, but a lot of theories don't pan out when you actually do the study, so you can't say for sure. I think the promise is there is a large registry right now looking at patients specifically on belimumab or Benlysta. And it's been very difficult, as you might understand, to enroll patients in these studies because most people aren't going to want to stay on these medications. But the early data have not shown that there is any harm. But it becomes a really personal and difficult decision to make because you're making a decision, with at least one hand over your eye.
Yes, yes. And those choices are, we talk about this a lot in our community here. The weight of the choices, a lupus patient, I know that we're not alone with chronic conditions, that chronic conditions in general are just difficult and how they impact your life in so many ways. But with lupus and the systemic way it impacts the body, and now talking about the reproductive element, the choices that a patient with lupus, male, female, have to make, it is so hard to have to take your emotional component and your dreams of the future and family planning, whatever that looks like to a person, and then the structural elements that are embedded in your DNA with this illness, and have to kind of marry these two and make these decisions. Oh, it is so hard. It is so hard. um, I think it's hard at any stage of life, and maybe this is a good way to dovetail and transition into maybe those that are watching this that are no longer planning a pregnancy, but are looking in the next stage of their life with menopause. And there's a lot of questions about menopause, and I didn't ask this of you before, so I apologize for throwing this at you, about, is it good? Is it bad? The hormones changes. We know anytime there's a fluctuation in hormone changes, it can impact disease activity. But is it better before, but better after? Just would love your intake on those that are watching today in that stage of their life.
Yes. Such an important question. And, when we think about menopause, there are so many lupus specific things to consider, whether what time menopause will come, how people will experience it. And everybody experiences menopause differently. I think a very common question I get is, should I get on hormone replacement therapy?
Yeah.
And I think the first thing I would say is that we don't have a lot of great data to really guide us here. But we do have some low-level studies that have told us that if you are on hormone replacement therapy, you really need to know, again, your antiphospholipid antibody status, because the big concern when it comes to hormones is that they can increase your risk of blood clots and certain types of cancers. And so we need to make sure that we really understand what is the remainder of your risk for blood clots. So when you have something like antiphospholipid antibodies, your chance of a blood clot goes up significantly. And in that case, we really recommend avoiding HRT because of that blood clot risk. However, if you have lupus, but you don't have those antiphospholipid antibodies, then some studies would suggest that it's safe. The challenge in that situation, however, is that lupus itself increases your risk of blood clots, even if you don't have those antiphospholipid antibodies. And so there is this risk that getting on a medication like hormone replacement therapy that can also increase your risk of blood clot, there is a risk that you could go on to develop something like a blood clot. And that's really, as rheumatologists, what we worry about. But apart from HRT, I think the other thing that's really important and really under-recognized is the importance of osteoporosis and bone health. And think that becomes particularly important postmenopausally because osteoporosis is a completely silent disease. You don't feel it until you break something. It's So when you have a disease like osteoporosis, all it means is your bones are weak. You don't feel that, but you're much more prone to breaking something. And it's not a break like you fall off a ladder and break your arm. It's like you twist your wrong way in bed and break your back, or you trip over the rug in your living room and you break your hip. And those can be really life-changing injuries. And that's the other thing that we really want to make sure we pay attention with in lupus, because lupus itself can increase the risk of osteoporosis, and a lot of the medicines that we use in lupus can make your bones much weaker. So making sure that you're getting DEXA scans or a bone density scan regularly is really important. And I'll add one caveat to that, which is if you are on a high dose of prednisone, or you've been on prednisone for a long period of time, it's also important to check your bone health even before menopause.
What age would you recommend your patients, if they've been on steroids long term, to check their bone density? Asking for a friend, just kidding, me.
I think it really comes down to how long you've been on the steroids before and how high of a dose that you've been on before. But for most of my patients that have been on, we say for adults under the age of 40, if you've been on steroid, if you've either had a fracture before, or if you've been on very high doses of steroids for long periods of time, after like 2 to 3 years, I would get a bone density. In fact, if you've been on very high doses of steroids, so more than 5 grams in a year, or kind of the equivalent of 30 milligrams a day, I would actually get a bone density scan initially, and or might even treat you preemptively for steroid-induced osteoporosis. So for some of our lupus nephritis patients, really high risk, we'll actually treat them for osteoporosis prophylactically because of how much steroid they're going to need to be on.
Interesting. Wow. Yeah, that's the prednisone and osteoporosis increased risk is always a really good conversation to have. We are running out of time here. We're in our last 5 minutes, and selfishly, I have so many other questions for you. There was a question about Sjogren's syndrome, and that impacting either obviously impacting intimacy, but potentially impacting reproductive health. Any thoughts on Sjogren's syndrome, common lupus overlap condition?
Yeah, that's a great question. The thing that we classically think about with Sjogren's syndrome, whether you have Sjogren's or not, is the presence of those SSA and SSB, or the Rho and the LA antibodies, because of the increased risk of neonatal lupus. We don't think that Sjogren's itself impacts fertility or your ability to get pregnant. But, I think there's a big part of Sjogren's that we don't talk about enough, is how much vaginal dryness can occur and how much pain with sex can occur when you have Sjogren's. Sjogren's is the autoimmune disease where it dries you out. It dries the organs that make your tears and make your saliva, but also your vaginal lubrication. And so a lot of my patients with Sjogren's, we really try to also talk about sexual health and how they're overcoming that as well.
Wow. I mean, I'm sure many people watching this now and streaming this later sadly would say that they've never had that conversation with their rheumatologist. And it just means the world to us to know that the work that you're doing, Dr. Lockwood at the Lupus Program, you're trying to change that for us now, but also for future generations to come. There was a question about pregnancy and anemia, and how obviously blood clots are an issue, but also low iron levels are. And is it safe to take iron infusions during pregnancy? Is it bad postpartum? The last few minutes we have, and then there's another question I wanted to get to real quick as well.
Yeah. That's a great question. And that's I think, a deceptively complicated question, because anemia can be caused by so many different things. And so I think that probably the first thing I would want to know is what's causing the anemia. Is that a part of your lupus? And is that a sign that it's your lupus flaring? In which case, is this a safe time to get pregnant? But anemia can be related to diet issues. It can be related to side effects from medications. Many people have concomitant thalassemias and chronic anemia or iron deficiency. And so I think it really comes down to what's causing the anemia and making sure that you're treating that. But yes, a lot of iron supplementation is very important with pregnancy and is an important part of prenatal vitamins.
Yes, absolutely. Well, I think we can say one of the biggest tips of the day is know your antiphospholipid status. I heard you say that maybe 4 or 5 times.
Yep.
And I am so glad you did, because so many lupus patients have no idea if they are positive for their antiphospholipid antibodies and their SSA and SSB antibodies.
Yep.
And they have no idea what their levels are and what that even means. And if someone is positive for antiphospholipid antibodies and they've been diagnosed or recently have discovered they are actually living with antiphospholipid syndrome with their lupus, is it a simple thing where they take an aspirin? Is warfarin, safe during pregnancy? And how do you kind of move forward with that? Because I know a lot of people have had, sadly, so many miscarriages, and I want to be so sensitive to that. As I know, experiencing pregnancy loss myself as a lupus patient, it is so incredibly, let's just call it what it is, traumatizing. And if that could be sidestepped in one way, I feel like what you're saying is get and know what those levels are before you start this path.
You need to know what your antiphospholipid antibody status is. And I think part of having lupus is learning how to be an advocate for yourself, because there's so much that you're not going to be able to cover in your doctor's visits. There are so many things that we neglect to ask and talk about in our visits. And so really, I think the biggest take home here is to really empower people to advocate for themselves and ask these questions and push your doctors. I love it when my patients bring in questions so that we can dive into things in more detail. When it comes to antiphospholipid antibodies, it really depends on if you've had a blood clot before and if you've had a pregnancy loss before. There's a few different types of antiphospholipid syndrome. And depending on the type that you have, then you would need to be on a blood thinning medication during your pregnancy. And usually it's something called Lovenox or low molecular weight heparin. So it's a daily injection that you give for yourself. Warfarin is 100% not safe in pregnancy. However, it is completely fine to breastfeed with warfarin. And I think that's something that people forget about. As soon as you give birth, you can go back to your warfarin or your Coumadin. You don't have to keep up with those injections. We always have our patients get on a low dose of aspirin as well, and make sure that they continue on the hydroxychloroquine or the Plaquenil, because in both lupus and in antiphospholipid syndrome, they have significant benefits for both mom and baby.
Absolutely. Thank you so much for that. One last question came in. It says, what is your intervention? I think this is a healthcare professional for a patient with 6 weeks of pregnancy, and she has received cyclophosphamide. There we go. Sorry. It's playing tricks on me.
So that is when you really, well, one, I would say if you've been on cyclophosphamide, I guess my question would be, are they actively on it or had they received it in the past? And part of the reason I make that distinction is because one of the biggest concerns with cyclophosphamide is just that you can't, it reduces your ability to get pregnant. So the fact that if you've been on cyclophosphamide and then are able to get pregnant, that is not common. And then at that point, that's when we really work closely with our MFM, maternal fetal medicine specialists. So they're kind of the high risk OB doctors to really try to assess what is the status of the fetus? What is the intention of the mother? Is is this a desired pregnancy? And if so, what do the risks of this pregnancy look like? What do we know about the development of the fetus so far? But it is a medication that, we will occasionally use in the second and third trimester, but we do think that the congenital anomalies, if they're actively on it, particularly occur in the first trimester. So it's a really challenging situation in that
It's challenging. Yeah.
So what are those other decisions that you're just faced with as somebody with lupus?
Absolutely. Yes. Well, we have unfortunately run out of time. I almost feel like we need to do a part two because I have questions still, and I'm sure people watching do as well. I just want to thank you so much for your time, Dr. Lockwood. And where can people find you to hear about the work that you've been doing, your program, your clinic? Are you on social? Where can people find you?
You can find me at Georgetown University in DC. We're building a wonderful lupus program here. We have a dedicated group of providers that are committed to caring for people with lupus and providing people with opportunities to get involved with clinical trials, which is a huge part of living with a chronic illness that doesn't have a cure. If you go to Georgetown University, Medstar Georgetown University Hospital, Megan Lockwood Lupus Program, you can find me. I don't have much of a social media presence. That might change in the future, but right now, just the website's the best way to find me. And if anybody's in the DC area or has any questions, I would be more than happy to chat. And I can certainly put my email in the chat as well if anybody wants to reach out. And I'm always happy to take email questions and get you plugged in with care.
Oh, well, thank you for that. That's so very kind of you. And ACR is in DC this year,
It
so
sure is.
maybe I'll get to meet you in
I
person.
would
That
love
would be
that.
so exciting
I'd
because
love
I know
that.
you're originally from Oregon or lived in Oregon for a
I am a
while. So
native Oregonian, and my
yeah.
whole family is still there in Portland. So
Oh, that's so great. That's wonderful. Well, lots of people are expressing their gratitude and really enjoyed today's presentation. And I thought, why don't we just end it on an even more fun note and do a little drawing? We've got some great lupus awareness month swag for everybody here. So I have the names of those that have shared this chat, and I'm going to do a little spin the wheel here on my fancy spinner. And it's Carrie. Carrie, congratulations. Do us a favor, send us your address. I know I have it somewhere probably because you've been with us for a while here watching our stuff, but go ahead and send that to us. This will be available on YouTube by tomorrow. So for those that who don't have social, don't have Facebook, you can at least share this with them on YouTube so they can get their hands on this amazing information. Thanks again to our esteemed professional, Dr. Lockwood, and we hope to work with you again soon. This has been wonderful. Thank you for your time.
Thank you, Kelly.
Well, we have a few days left of Lupus Awareness Month, so keep coming back to More Than Lupus and morethanlupus.com to see some great information and resources, and we'll see you next time. Bye-bye for now.